Okay, well, I think it's time to start. So good evening, everybody, and welcome to this second webinar in the BAUS Innovation in Urology webinar series. I am delighted that tonight we're going to be covering technological advances in endoscopic combined intrarenal surgery. This webinar is sponsored by EMS. The webinar is going to be as an as-live case, which is conducted by my two colleagues from Addenbrooke's Hospital, Laurian Dragos and Kasra Saeb-Parsy. So without any further ado, I shall hand over to Uli. I just want to say that please, let's try and make this interactive. There's a Q&A box at the top. Please answer any questions through there. The two panelists will answer your questions live. Some may be typed and some we may read out and answer verbally. So Uli, if you want to just explain a bit about EMS and then introduce the webinar. Thanks very much.
Yeah. Okay, then you should give me the screen. Yeah. Okay. Yeah, good evening, ladies and gentlemen. On behalf of EMS, I would like to welcome you for this so-called BAUS meeting. Yeah, I'm happy that EMS is in cooperation with BAUS and we have the chance to sponsor this webinar. Just a few words about EMS. We are a Swiss company founded 35 years ago in a small valley called close to Geneva. This is where we have our headquarters, and this is the nice view out from the office at Lake Geneva, about 20 minutes apart, away from Geneva. A nice territory, a nice region, unfortunately very expensive. But yeah, that was the time when we developed all our urology devices that most of you may know. This is a small overview when we started with the first lithoclast, which was a pneumatic one, then a combination device, the lithoclast master, phase up of the first lithoclast, the lithoclast true, a handheld lithobreaker, pneumatic lithobreaker, then the first laser in 2012, and then 2018, this device was launched, the EMS Swiss lithoclast Trilogy. So that combined pneumatic, ballistic power and ultrasound in one single probe. And last but not least, this is the new laser class launched in 2020. Both devices, the Trilogy and the laser class, will be used in the surgery you will see after my quick presentation. And just a quick overview about the features of the laser. This is a 30-watt holmium YAG laser, and we have a pre-setup, which is easy to manage, easy to handle. A foot pedal where you can switch through the different modes, lithotripsy modes. We have a presetting of the hardness of the stone from soft to super hard. And this device can be, on top of this device, the Swiss lithoclast Trilogy is mounted. So whatever the stone is, whatever the situation is, you can treat with these two devices all stones, wherever they're located. And yeah, this is the last slide. Thank you for your attention. Thank you for joining, and enjoy the show from Dr. Laurian Dragos, urology consultant at Addenbrooke's Hospital in Cambridge, and Dr. Kasra Saeb-Parsy, also urology consultant at Addenbrooke's Hospital. I hand over the mic to you guys. Please start your show. I stop my screen.
I'll share the screen. Okay, thanks very much, Uli and Ollie, for the introduction. And as again, I would like to extend our welcome to the delegates who are here. So, as Ollie's already mentioned, we would be presenting as live case. This is a 70-year-old patient who was referred to our hematuria clinic with a history of visible hematuria and recurrent UTIs. She had been on prophylactic antibiotics. Despite that, she was having UTIs, which were becoming resistant to antibiotics. So she underwent a flexible cystoscopy. And in our department, the policy is that a patient with a high risk of malignancy will have a CT with contrast, provided that the renal function is adequate. As you can see, this patient has got stones extending both in the mid and lower calyces. There are also some calcification in the upper pole. The contrast CT does not show any other abnormalities. One of the questions that's quite often asked, do we need to perform routine contrast CT scan, which we don't. We only, generally speaking, for our patients, when we are planning our PCNLs, if there is any concern about the anatomy, we'll go on to perform CT with contrast, but otherwise we simply rely on our non-contrast CT because nowadays we can perform 3D reconstruction. I'm going to hand over to Laurian, who's going to talk about the laser equipment that we've used from EMS, and then I'll talk about the Trilogy.
Hello everyone. Basically, we've pre-recorded this short presentation of the laser machine and the Trilogy, so I'll start this with the volume on. Ollie did touch a few aspects already.
What's interesting and good is that it's very easy to use the stone settings. For example, you have soft stone, medium stones, hard stones, and super hard stones. So just for example, I'm not going to run through all the settings, but let's go with the medium stones. And then, as you can see, there are some presets done for dusting, fragmentation, or popcorning. For dusting, the preset is 0.5 joules and 20 hertz, but you can easily adjust this if you want lower power, for example, by pressing the buttons. And obviously you can decrease the frequency if you want to. And then you have the fragmentation setting, which is 0.8 joules and 12 hertz. Again, you can modify this. And for popcorning, it's similar here, just because I've played with it, but you can obviously increase it or decrease it by according to your preferences. And then what's very useful as well is that you obviously can adjust the pulse from long pulse to short pulse. But as you know, the only time when you really need the short pulse is when you fragment. And as you can see, it's preset for short pulse. Again, dusting long pulse, fragmentation short pulse, popcorning long pulse. So you don't really have to know all these things. You just have to start with these settings and then adjust the machine according to your preference. Another good thing is that you have this pedal, which is easy to move, as you can see, and it is large enough. So even with my large boots, I can press the pedals. And this is the red one is the laser activation, and the black one is the one that changes the settings. So you can run through the settings without needing to have some help with you. You can just change them while you're using the laser. And the button here in the middle, which is well protected, is good, is to basically put the laser on standby or restart it in order to make sure that you're not damaging the scope or whenever you're adjusting something. So that's the laser, this part, and more.
So to give you, what I will do is I will give you a brief overview of Trilogy. For those of you who haven't used it, we acquired our own Trilogy machine about a year ago, and it really has changed the way we do things, and we have found more and more uses for it. The advantage of Trilogy is that it is a hollow single probe device, which allows you to combine ultrasound as well as ballistic energy and suction. Being a single probe device allows a bigger surface area, which means allowing more suction, and also allows you to remove a larger fragment, therefore increases the efficiency during the procedure. And hopefully we'll be able to demonstrate some of these effects during the procedure. But also it's a very versatile device. In addition to just being held like a gun, it allows you to control all the energy sources, i.e. the ultrasound and the ballistic, separately, and set the levels to what you require, in addition to altering the suction level. Again, hopefully you'll see during the procedure where we have played around with the energy levels, including the suction, in order to get the optimum requirement in order to clear the stones. So it really does make a big difference. And the other advantage of it is that it is bit like the laser. It does have a foot metal where you can, by pressing it halfway down, you can activate the suction, and by depressing it fully, then you activate the energy source, whatever that is, whether it's the ultrasound, the ballistic, or the pure suction. It also has the stone catcher where you you have the you place the stone catcher, and you'll be able to see that during the procedure. So we're going to move on to the actual procedure. One of the questions which already has come through was from Graham Watson, and it's a debate which is often had: should the radiologist gain their own access, or should it be done by the urologist? That's a very good question. And in Cambridge, we're very lucky to work very closely with fantastic radiologists, where we discuss the cases beforehand in our stone MDT, before the PCNLs. We decide where is the best approach in order to get the best stone clearance. So it's not a case of the radiologist turning up, getting access where they can. It is a discussion with the radiologist. And our radiologists, as you can see, use a combination of ultrasound and imaging in order to get the best access. For example, in this particular case, we had already discussed, should we go for the upper pole approach, mid calyx, or the lower calyx? But if you go back to the, take your mind back to the original CT scan, the lower pole was more anterior, and also it was surrounded by colon, which would have been very difficult. So our decision was to go with a mid calyx approach in order to try and clear the stones in the mid calyx, as well as the renal pelvis, knowing that there is further stones in upper pole that we will require to use flexible ureteroscope in order to clear that, which was an ideal case for a combined approach. You can see our radiologist and the Winterbottom is trying to, has already got the wiring, trying to dialect the tract with a significant degree of movement in terms of the kidney. We always use 2 wires, one wire safety and one for access. Again, you can see later on during the procedure that you have to adapt and you have to change things, and actually have 2 wires there was impeding our progress, and we've had to change tacks. We tend to use Nephromax dilators, and in this setting we use the 24 French dilation. We used to do 30, we've gone down to 24 purely because of the larger stone burden. But depending on the stone burden and expertise, other people may use a smaller track size. And some of the things that we can discuss later on is what do you do at the end of the procedure in terms of whether you do a tubeless PCNL, whether you do with nephrostomy or with stents. So here in the process of trying to achieve our dilatation, there's lots of debate about whether we should use balloon dilation or whether we should do serial dilatation. We tend to favor balloon dilatation, particularly in this case, but we can discuss that later on as well. As you can see, having got the contrast in the balloon, we can see the nice dilatation of the tract, and we're almost ready to start the procedure.
Kasra, I wonder, can we just pause the video for just a second? Just a question from Graham about the exposure that we're getting from the II there. He's suggesting that there's quite a lot of X-ray being done there. What are some of the methods that are done to minimize the exposure to X-rays, and what are your thoughts about what he says?
I mean, that's a very good question and is a valid concern. So the X-ray is controlled by the radiologists themselves. So they're fully aware of the exposure radiation. And so they do tend to cone in order to get a very focused view in order to reduce the exposure. So it's one of the things that obviously they're very aware of it.
Yeah, so I mean, you know, this isn't coned in, but often it is, I think,
Yeah.
is the point
Yeah.
that's worthwhile making. It is normally pulsed. I'm not sure if it is in this case. And the other thing I'm not sure that we saw was the ultrasound access, was that the access at the beginning actually for the needle is controlled by ultrasound. There's, you know, little X-ray, isn't there, at the start? It's just really to check which calyx is being targeted.
And just purely during the dilatation when you're using the balloon. That's right.
Yeah. And there was just one more question, Laurian, just about the pulse duration of the laser class. So that would be good if you could just cover that before we get on to the positioning of this particular patient as well, which is another question that's come through.
Yeah, sure. Honestly, I don't know exactly the numbers from the producer, from the manufacturer, so maybe Uli can help us with this. But I remember from a previous discussion that I had with Uli, and we were discussing about these settings. I think what they are, this machine should be around 200 for short pulse, yeah, and around 800 for microseconds for long pulse. But don't take it as very exact numbers. This is what I think. Maybe the manufacturers can let us know more.
Yeah.
Exactly.
My colleague Graham will answer the question via the chat.
Okay, that's perfect.
Yeah.
Thanks. And then there's just a question on the positioning, I think, which I'm not sure if you covered between you, about prone or supine, what you've done in this case, what you normally do.
So, I mean, generally speaking, you know, in this particular case was a supine, modified supine position, and certainly in my experience, you know, we have moved away from prone PCNL, and if we can do it supine, we tend to favor supine positioning for a variety of reasons, particularly in this case where we were planning to a combined case. Then it would have been much easier to perform the procedure in a supine position, notwithstanding the sort of the benefits in terms of the anesthetic and so on with regards to a supine position, and in terms of the timing and positioning of the patient, saving times in terms of supine rather than prone.
Yeah,
right. So in which sort of cases would you go for a prone approach?
What I wanted to say, and it fits in with your question and comment. Basically, we are very spoiled here. We have wizards like Andy Winterbottom, amazingly skilled interventional radiologists. They can puncture the kidney basically in any position, and we are carefully planning before for each patient and the access and obviously the position. So there's no rule like we are going to go only prone or only supine, and we can adapt. We always adapt these things to the patient's particularities.
Okay, great. So we have one more question just from Azad Hawizi, who's saying, when you need to access the balloon will not be the best way to dilate the second access, as it cannot be dilated fully. So maybe that's about whether you have two accesses and whether you put them both in at the start.
Yeah, so you can obviously you can we do have now smaller balloons, and we can do a 24 French tract with a smaller balloon. Or if not really needed, if you just need to get in, you don't need to use the balloon to dilate. Here, I must admit, we are not using other type of dilation or tract dilatation, but we can still use the alkane dilators if necessary. What do you think, Kasra?
Yeah, definitely. And, you know, I think, for example, if we're doing a purely an anti-grade ureteroscopy, then, you know, we would use, you know, we would go to 11-13 French dilation using the standard access sheath. So if we anticipate that using a smaller mini PCNLs, then, you know, we'll adapt and use a serial dilator. And if you're going to use multiple tracts. And one argument is that, well, we could have done two punctures for this particular case rather than one to clear all the stones, but we felt that each puncture increases the risk, and we will have good access where we can do the procedure simultaneously, i.e. one person dealing with the pelvic stone and the other person starting the process for the retrograde approach.
Okay, well, we can see how things go, but I guess what you're saying is if you've got a combined approach, an endoscopic combined, then that's the advantage, is you're much less likely to need a second access.
Definitely, we tend to avoid this if possible.
Yeah, but if at the start you predict that you're going to need that, then you'd put both wires in at the start, because it's much easier to get the wire in before you've dilated and decompressed the system.
Yeah.
All right, perfect. Well, sorry, let's move on then.
Okay. So I'll just slightly fast forward because we've covered some of these aspects. So it's setting up the Trilogy. I quite like the wrench that they have provided, so you don't have to worry about the amount of torque that you're providing to lock the probe. It's, as you can see, it is a quite nice device where you insert it into your probe, and it releases it sort of once you've reached the set amount of locking, that it produces the sound, which is quite scary when you hear it the first time because you think you've broken it. So we've introduced our nephroscope into the tract. As you can see, there is blood there. Under normal circumstances, I would have used the grasper in order to try to remove the clot in order to see where we are. However, with the suction that the effective suction that's provided by Trilogy, you know, I'm just using the suction in order to clear the clot, in order to see whether we've actually punctured onto the stone or not. As you can see, the stone's starting to become visible. That you can see that we've had a direct puncture to where we needed to be, rather than getting access anywhere that we could. You can see that there's also a fair bit of small stones lying around, and you can see our wire there, and I've already started to use the suction with a bit of ultrasound to try to fragment the stones. As you can see, it is fairly efficient. Actually, this was quite a hard stone, and the Hounsfield unit were the average Hounsfield unit was 1400, so we suggest a fairly hard stone. So the very start of the procedure, you know, because the stone's impacted in the renal pelvis, you know, we've got the ultrasound on maximum, the ballistic on maximum, and on suction fairly high as well, because I'm not worried about the retropulsion, the stone moving around. I just want to create enough space to get a good circulation, to get a better view, and get all the fragments out. However, as you can see in the other screen on the other side, Laurian's already started to try and introduce his flexible ureteroscope into the ureter, not waiting for me to finish the procedure or make good progress, because we had decided that we should be able to make good progress and therefore carry on with the with our plan as a combined procedure.
Just a short comment. You've seen that we had two safety wires, two stiff wires down to the ureter. I was not able to pass the flexible cystoscope with both wires in there, so we had to remove one, and Kasra carried on with just one safety wire, which with one wire which worked as a safety wire down to the ureter.
And actually what I noticed that having removed the second wire, I had a lot more freedom, as is always the case, in terms of maneuverability and being able to fragment the stones. So I think this probably is a good point. You know, we've got a very good view, very good clearance, and all of a sudden I start to lose my view here. And so the first thing that I start looking at is saying, okay, why have I suddenly, having had a perfect view, I've lost view? And I look over my shoulder to look at the irrigation bag, and of course the bag had finished. And it just goes to show that you need to be aware, you need to have a team who's constantly aware of the surroundings, who's responsible to help you carry on the procedure very efficiently.
So Kasra, can I just ask, what's your strategy from the point of view of this stone? So, you know, is there a particular way that you're planning to break it down, to remove it in particular order? And then also, what is, you know, Laurian going to be doing from below at the moment? Because presumably the stone is occupying the pelvis up to the PUJ. So what's his contribution at the present time? Okay.
So my plan was that what I didn't want to do was end up with a long stone. What I wanted to do, and I'm just going to pause the video here for a second. What I wanted to do was trying to reduce the surface area and make it a flat stone if I could, rather than keep going and make a big hole for myself. However, as you probably appreciated, that, you know, I was really struggling to begin with to try and to avoid that. So I did have to create enough space for myself to try and tackle it from underneath in order to make it crumble. So therefore I could access it much better that way. Okay. But, you know, if you can get it flat and shave it all off, that'd be much easier, rather than ending up with a long tunnel that you have to end up with lots of bigger fragments.
Yeah. Okay. And it looks on the image intensifier that we just saw, Laurian, like you're kind of poised and waiting to get access up into the kidney for Kasra to kind of free up the PUJ. Is that right? You're just kind of ready and waiting, really.
Yeah. Exactly. So I mean, you could see on the previous there. Yeah. So, you know, Laurian was there waiting for me to clear the access area, which rather than wait for me. And you're using a reusable, disposable flexible ultrascope. So we're not too concerned about damage to the scope, because it's just we'll be disposing of it later on.
Okay, great, thanks.
And you can see now quite quickly, I would say, given the size of the stone, Kasra was able to solve the pelvic stone and the part which was in the interpolar area, and some fragments migrated in one of the infundibulum. So as soon as I was able to get into the pelvis, and you're seeing the nephroscope view of my scope, I got some of the fragments from one of the infundibulums and brought them to Kasra to break them and suck them through the probe. You'll see this image many times during this procedure.
So this is where we essentially start playing around with the settings on Trilogy. We've increased the suction to 100%. We have reduced the ballistic to about 20%, and we're essentially relying on the suction and ultrasound in order to reduce the retropulsion and trying to get the stones fragmented and sucked up.
Exactly. So you have the screen, the display of the Trilogy. So 20% ballistic, 100% ultrasound, and 100% suction.
And your impact is down, is it, to try and stop the stones from moving away from you?
Exactly. Yeah.
Yeah, and to try to you know, when you push them, you'll see that given the access, most of the stones they tend to go down to the PUJ area.
Yeah.
So obviously my scope is there, but it's still I'm trying to stay away from the nephroscope and from the Trilogy probe.
Yeah, yeah.
Here, just to explain what's going on, it was a bit difficult for me to maneuver the scope, and honestly, I didn't understand. At the very beginning, I was not really aware what's going on. Why do I have this difficulty? Because looking at the CT beforehand, I thought it's going to be quite a straight and easy access for me to the upper pole to bring those stone fragments or those stones from the upper pole down to the pelvis. But I was really struggling, and you'll see in the video that I had to maneuver and to turn the scope completely upside down. And I'll show you why. However, just to orientate a bit, just to get the architecture of the kidney behind Kasra's probe, I've asked him to stop the lights. And then on the right hand side part of the screen, you see a very nice image of my scope in the dark, looking and assessing the collecting system just in a few moments. So you see basically the huge difference between the light provided by the flexible cystoscope and the the excellent light provided by the nephroscope. So, but I think it's nice. It's like
it's a flexible ureteroscope that you had.
Yeah,
yeah. So we've got a couple of comments which I really want to just mention. So Mike Kellett has said, "I admire your minimal tracks. Good to see all Wickham did to start minimal intrarenal surgery," which is nice. And then Graham's asked about, do you agree that smaller track makes for less bleeding, and that this is important when doing a combined FIRS PCNL? So do you want to talk just a little bit about the track size and minimization, and when you might maybe do a mini, or what sort of track size you're using here?
So I mean, it's interesting that small is definitely better. A few years ago, our tracks used to be 30 French. Now we've moved down to 24, and people are now using 16 French and so on. So definitely, the smaller that you can get away with, the better. Decreases risk of bleeding, and in terms of you could argue that in terms of the nephron loss as well, small is definitely better. Interesting for Trilogy, they have different size probes. They have the 5 French probes that can be used even for mini nephroscope. They have the 30 French which can use for the maxi PCNLs, and the standard ones that we use for 20 at 24. And I have never used them on. They have the 4 French ones which they use for, they advocate that it can be used for semi-rigid ureteroscopy. If anybody's used that, I'd be quite interested to hear and see what their experience was in terms of using that.
Yeah, great.
Yeah, you have to pay attention whenever you try to do this and pass through you were saying about ureteroscope, wasn't you?
Yeah, so I've never used it, so they say they can.
Yeah, the thing is, be careful to make sure that your probe is long enough to go out through the scope. So you have to you have to take into consideration not just the working channel of the ureteroscope, of the semi-rigid ureteroscope, but also the other part. So altogether, it has to be shorter than the probe.
One of, we're going to slightly digress here, but one of the things that we've started doing a lot using our Trilogy for dealing with complex bladder stones in patients who've had recons in terms of Mitrofanov or bladder substitute, or they've got sphincters where access through the urethra or through the Mitrofanov is very difficult. So we've started to use that in terms of getting a direct puncture into the pouch or into the bladder substitute, and in order to get a fantastic clearance of the stone because of the excellent suction and the ballistic and ultrasound. Again, Laurian, you recently did a encrusted stent using Trilogy, didn't you?
No, I did. I wanted to tell you about the probe, the thin probe, because I wanted to use it in a 16 or 15-year-old boy with bilateral diverticulums, blood diverticulums, and with very thin necks, and in one of the diverticulum was a quite large stone. I was planning to use to minimize the trauma to the urethra, to go directly with the semi-rigid ureteroscope and to use the probe, the Trilogy probe, and to break the stone in the diverticulum and to suck it from there. Unfortunately, the probe was not long enough, so that's why I'm telling you about this. And I had to use the laser. Everything went well, but I would have loved to use the probe and to solve them.
Yeah,
that would be the 450mm probe then, rather than the shorter one.
You probably have to use the 625mm one for that, actually.
Exactly. Yeah.
Which we don't have in our books, but you have to have the 625.
The 45cm probe is not long enough. Basically, the length of the working channel of the scope is 45, and you have to add the connectors, so it's not long enough. So
okay, we've got a couple more questions, if that's okay.
Sure.
So Kay Thomas has asked a couple of questions. She wants to know about the reported increase of sepsis with smaller scopes, so I guess with the mini PCNL, and whether that's something that you've noticed because of the increased pressure that that you have in those cases.
I haven't. I will let Kasra comment on this. With the mini PCNL, normally you shouldn't have too much pressure, because it's more or less designed to be an open system. You don't work with it closed as you may work with the normal side, the standard PCNL. So I haven't noticed it. Maybe Kasra.
I mean, I think that's a very good question and a very valid question, and that was something that was asked us when we presented one of our cases which we did at BAUS, where we had done a percutaneous bladder stone surgery for a foreign object at the same time as performing a rigid ureteroscopy. The reason we went ahead with that, because we had a 24 French access into the bladder. It was a low pressure, and therefore we felt confident enough to go ahead with proceed with the stone clearance in the bladder, then go ahead with the ureteroscopy. So keeping the pressures at the minimum level at all times is really important to prevent, the sequelae of infection and sepsis, which can be very life-threatening in these situations.
Yeah, I think the kind of question was that the pressures are higher when you do a mini PCNL, and so there have been some studies which have shown an increased risk of infection, but I would say that we probably don't do enough mini PCNLs ourselves to see that coming through in post-op cases. And then she's also asked about whether you have your outflow off whilst using suction to stop collapse of the collecting system.
I don't think we had the outflow off during this procedure. Later on, you will see where there were, towards the end of the procedure, there was this collecting system was collapsing, and all we did was decrease the suction there. But we hadn't noticed, there was no need for us to turn the outflow off during this procedure.
Okay, that's great. And then Will Finch has asked whether there's a role for traditional pass-the-parcel and extracting the stone with forceps, or is Trilogy more efficient than this? We talked about that, and I don't particularly like. Before Trilogy, we used to do that all the time, get the graspers out and make a bit of a mess in terms of bleeding and touching the mucosa. But it is fairly effective, and you will see later on how I have used Trilogy essentially as a grasper in order to get the fragments out. So it's a very good question, Will, and you'll see how it's replaced my grasper. So during this case, I did not use a grasper at all.
Yeah. So
right. Perfect.
I just started. Yeah. Sorry.
No, I was just going to say, so Azad Hawizi has asked another great question, which I completely agree with. He's saying that when you've got the Amplatz sheath in, sometimes it's really difficult to navigate the kidney with a ureteroscope or a flexible nephroscope because of bleeding and collapsed calyces. And I must say that the view that you've got is certainly much better than the view that I normally have when I try and do that. So, what have you done differently? And have you got any tips as to how, you can help people to improve the visibility and to stop this collecting system from collapsing when you're doing a flexible ureteroscopy combined with a PCNL?
So I can't take credit for the lack of bleeding. I think that it comes down to our radiologist probably having had a good puncture. You know, there's a debate, you know, where do you puncture? Do you just go anywhere, or do you try to use a, you know, more avascular plane? Manipulating the sheath in order to get an optimal position in order to prevent the bleeding. But I think sometimes it's one of those things. It's you just have to be lucky to some extent and not have the bleeding. And if you do have the bleeding, you just have to deal with it. And if there's a collapse, then as Kay said, you know, you have to do, you can close your outlet, decrease the suction in order to prevent the collapse of the system.
So I fully agree with Kasra. It starts with the puncture if it's well done, and you don't. Sometimes you do the puncture correctly, and then the infundibulum is very tight, and then you have bleeding because you're, you know, dilating the infundibulum. It was not the case in our situation. Then also the quality of your device, the stone breaking device. If it breaks and you don't have to push too much against the mucosa, and you don't have to move too much, if you have good suction and basically suck the stones to you instead of chasing them, you know, all these tiny details might altogether they might provide you with more comfort and less bleeding during surgery. So are there any more questions? Should we carry on?
Well, there is one more question. I don't know if anybody can see it, but I'm afraid I'm completely unable to translate it. So if anybody is able to translate it, then please just type it into the Q&A. And if anybody's got any more questions, rather than putting your hands up, please ask them through the Q&A. But I think that Uli wanted to just share some more poll questions at this time. I don't know if it's a good time to break off, Uli, and just do that before we come to the end third of the case.
Okay. So that's a good place, because, you know, this is now where they're connecting the laser for Laurian to start doing a bit of lasering using the EMS laser. So yes, it's a good time.
Yeah, I hope everyone can see the results.
The results were available earlier, Uli.
Yeah, I know.
Thank you.
So, which shows that, as Kasra said, there's a trend to miniaturize, coming from standard PCNL to mini PCNL. Surprisingly, the URS is being used more than PCNL, but ECIRS might be a good compromise between both procedures. Maybe that's the result. Do you want to comment something of the results from the poll question, from the first poll question, Oli? Or
yeah, Kasra, Laurian, is there anything that you'd like to add on that? I mean, I think people are doing more endoscopic combined. I think supine is certainly you know, gaining you know, a positive feedback, and it's being adopted. And with supine, I think that the next step to do the endoscopic combined is much easier than if you're in the prone position. And I think more and more big centers now are offering a miniaturized approach with the advantages that that's got, that Kasra's mentioned. So I think that we'll expect to see that trend. So energy devices which help us to you know, operate with a mini access, I think are going to certainly be very helpful. I don't know what your thoughts are, Kasra, Laurian.
I think those are very valid points and very true. But I think what's more important is what the surgeon and the center is comfortable with. And you know, there are some centers that, you know, they continue to do 30 French and they're very good and they get very good clearance. So it's important to do what you're happy and comfortable with and confident with, rather than just using technology to improve you. Technology is there to help you improve things, provided that you're happy with it.
Yeah, I think it's a natural tendency to miniaturize if you get the same, more or less similar results. And this is something that we're definitely going, I think we are going to see in the future, we will have smaller flexible ureteroscopes, and we already, mini PCNL with or mini combined approach is quite often used now all over Europe. So yeah.
Did you have the second polls that you wanted to do now, Uli?
Yeah.
Okay, great. So just a couple more questions before we move on to the lasering part, and then we can have a discussion, I think, Laurian, maybe about the high power versus low power lasers, about the importance of pulse widths and those sorts of things, if that's okay.
Yeah,
great.
sure.
So there's just a poll here if people are. So just while we're waiting for that, Will has asked about the positioning of bolsters under the patient for supine PCNL and how that can help with maneuverability of the sheath. So do you want to just talk about the positioning that you have for your supine endoscopic combined?
So we use the good old 3-liter irrigation bag that we use for our HOLEPs and TURBTs, and then we use a standard saline bag as well in terms of to get the positioning correct. And again, we have the person who's getting access there during the positioning. So it's not a case of just me being there. It's again, both the radiologist and the urologist are there positioning. And we do check with the ultrasound to make sure that we have a good enough access, both not just for the radiologist to get access to the kidney, but also then we talk about, well, if I go in this position, what about you? Where are you going to go? Are you going to be able to get enough access to get around the kidney? And we tend to use a modified approach for a supine PCNL.
Yeah. So I mean, Kay Thomas has just made the point that, the big change that we've got now over the last few years with percutaneous surgery is that we can really tailor and flex our approach. We've got supine, we've got prone, we've got mini, we've got ultra mini, we've got standard PCNL. So there's really, a lot of, careful choices that we can make to adapt to the situation for the patient in the stone, which is completely right.
Yeah, it's amazing and fascinating, isn't it? And if we can have all these tools, it's so good to be able to adapt to the needs of the patient. However, I don't know if you can clearly see. So this is with attaching the laser fiber. But if you, I'm going to pause the screen here. Or maybe no, I'll pause it. Basically, what I wanted to tell you is that having the laser machine and the Trilogy, so both lithotripsy devices on the same setting, it's quite same useful. Stack. Yes, same stack is quite useful. And what we would prefer, so in order to make things as safe as possible, you see the machine is very close to the working tray, and there's no space between this and the tray and the patient. So it's continuity for the laser fiber and for the all the cables that goes to the handle. So there's no room for someone to go by mistake in between and to pull the laser fiber, to pull the device out of your hands. And at some point you will have images with us operating, and you see we are close together. Everything is easy to reach, and maybe these details are important as well, right? We tend to think about them.
I think it's a very valid point that Laurian's made. He's very meticulous about laser and breaking fibers. Maybe that's because of his interest in the temperatures, but it is a very important point. And today I went to theatre and my registrar had started the case. There was a long laser fiber trailing between the laser machine and the case. And I almost broke a fiber because, as you know, they're very fine. And if you just enter theater, you're not really fully aware of the whole thing, but if there was no gap, that wouldn't have happened. So they had to stop me saying, you're about to break the laser.
Yeah.
So,
and look, this is, we are trying to be here as honest as possible. And this is really how the surgery went. It's edited in terms of cutting off some parts because it would have taken too long. But for example, here, I've inserted the fiber, and there are those moments when you put the fiber tip in, and then you look at the valve and you try to fix it. And look, my movement was quite impaired. I don't remember if I told you why, but you'll see in the at some point. It was due to the safety guide wire, which was down to the ureter, and it was really impairing my scope's movement. And here I was looking at my hands, and the fiber tip is touching the mucosa a lot. And you can easily just perforate or you have some bleeding. Obviously, it's not going to be significant bleeding. I did some there, but it can impair your image. And you see how there is a bit there. So, and then before starting, you see how difficult for me is to get a proper position. And it is, I didn't understand it at the very beginning, that it was due to the safety wire. Anyway, the decision was to keep it in and to try to adapt and work with it going in the ureter.
So Laurian,
yeah, sorry.
So I was going to ask, what's your strategy at this point for fragmenting these stones?
So look, it's a large calyx with a long infundibulum, which is not very, I wouldn't say it's very tight. It's not tight, it's just very long. I would rake them. I'm not going to laser them. You see, there's plenty of stones. I'm not going to dust them. I will try to, I usually start with tasting them to see how and adapt the laser settings to the stone. I think I've started with 0.5 joules and maybe 10 or 15 hertz. And then I've increased the energy to 0.8 up to 1 at some point. With 1, I had too much retrapulsion. So more or less, I think I've used 0.8 joules, 8 joules, and various frequencies. The goal was to break the larger bits and to try to remove them, to bring them with the basket to Kasra.
Okay.
Yeah.
It's interesting to say that this was the first time either of us had used this particular type of laser with the 35 laser. And with lasers, it does take time to get used to. I may increase the frequency to 50 hertz and have 0.2 or 0.3. So it's important to get to know your laser to see what it can do and how to play around with the settings. Yeah,
definitely. Look, it was the first time for me as well when I used it. It's a laser. It's a 35 watts laser. I'm pretty sure that at some point someone will ask, or Oli already wanted me to share my view or my opinion regarding the need for high power lasers. Yeah, obviously, look, we all love endourology. We love what we are doing, and it's like driving. If someone loves to drive, obviously, I drive a Skoda. I would like to have a Ferrari. I would like to, but you can easily do your job with 4 stones, and I'm talking about stones now, with a 35 or even a lower power machine. That's okay. There are some caveats when you are using the high power lasers, and you have to really know your tools and to be quite prudent in some particular cases. So, but I will stop this comment now. Please have a look at the right part of the screen. You see, I'm not holding the scope properly, or as I would usually hold it. I had to go and move it and work upside down, and you can see on the screen, just to try to get a better, to reach the stones in a better way. However, there are a few tiny or small tricks or things. So if you look at my fingers, maybe it's not the best view or image. When I'm holding the scope, yeah, you can see my hand. So the scope, I'm not holding it like this here. Yeah, I will try to hold it with this part. So the scope is more or less here. It allows an extra movement, and it even allows me to turn it and to use it and to use the lever with much ease. So it went, for me, it was unexpectedly difficult. The flexible uteroscopy part of this procedure, and you can see there's plenty of stones in there. I felt a bit frustrated. I was not very efficient. Yeah, I will just speed things up a bit. Obviously, at some point I will stop lasering and we will start bringing this. I'll insert the basket and we'll start bringing the stones to Kasra to basically do something. I was feeling like I'm not advancing very.
Just a couple more questions, if that's
Sure.
all right, which
Please.
have come through. So Will Finch has asked, what size laser fiber are you using, what's the maximum power that you can get with this fiber and this machine?
It was a 200 microns, and again, honestly, I didn't try this. I was just using what I needed at that point. I do not know what's with this laser, with this machine and this fiber, the combination, what are the limits? As we all know, more or less all machines have limits with different fiber sizes. So, Will, I'm sorry, I can't answer.
Well, Uli may be able to tell us, or somebody technical from EMS may be able to help.
Yeah.
So fortunately, the question that I was unable to ask has now been translated, and they'd like to know what kind of antibacterial therapy used for this operation, and the duration of it afterwards. So maybe you could just talk about your strategy pre-op, intra-op, post-op, for PCNL in general and antibacterial treatment.
Sure. So our hospital policy is that we use gent and amoxicillin. In terms of gentamicin, we use a 1.5 milligram per kilogram, so prophylactic dose. We did use augmentin cormoxiclav, that's been now changed to amoxicillin based on local sensitivity. In this particular case, if you remember, I did say that she was having a recurrent urinary tract infection resistant to nitro. So we did start her on oral antibiotics 3 days beforehand, and we continued for 4 days afterwards to complete this 7-day course. But and then we always check their urine, do a culture beforehand to make sure that it's negative. If we are particularly concerned, or patients who had a history of recurrent sepsis after procedure, we may bring them on the night before for IV antibiotics. We don't do that routinely, as long as we've given them adequate antibiotics beforehand.
Just a short comment about this image. Obviously, Kasra is not using the suction now, but I wanted you to see the dust coming, or the small fragments coming out through the infundibulum into the pelvis. While I was lasering, I was fragmenting the stones there. So I'm starting to retrieve some of the stones, or the larger fragments. It's again a long and painful process. I'm going to put it on, increase the video speed.
It might be, Laurian, but to be fair, it's a very complex stone, and you're trying to clear the patient in one sitting, which I guess is the advantage of an endoscopic combined, and it's also the advantage of you don't have to do 2 punctures in as well, so you've spared a puncture, but clearly for a large stone burden, fragmenting and then removing those fragments, you know, can be a little bit time consuming and tedious.
Yeah, definitely. If you watch this part, you'll see how long, maybe later on, you see how long the infundibulum was, and it was, again, not very tight, but tight enough. As soon as I bring the fragments to Kasra, things are getting much faster, much more efficient.
And you can see the amount of suction that it's providing. It is collapsing the system, but you know, my concern was that to try and get those stones. And what Laurian's doing with the basket is providing a bit of is essentially backstop of preventing the retropulsion that we have there.
So I think it's almost safe to, you know, start sucking and breaking the stone while it's still in the basket. We did it. Look here. So I'm going to go a bit backwards. Yeah. So for all of us passionate about stones, I think my colleagues have already seen that the core of the stone is of a different color. Yeah. It's much harder, and that's consistent with the stone hardness noted on the CT scan. And you see that Kasra has difficulties with this particular fragment to break completely, and the fragment goes deeper and deeper in into the PUJ. My scope is back there. Again, I think we are spoiled. We are using this very good single-use flexible scopes, but my instinct was to protect the scope and to prevent damage. And I was going, as soon as Kasra started to work with his probe, I was always going back below the PUJ, or trying to protect it, which at some point I realized is not really necessary. I'm going to throw it away anyway at the end of the procedure. However, you see, it's pushing and pushing and going down to the PUJ. And now my scope, so I decided to help in the end. So, and I pushed the stone back into the PUJ, and he sorted it out from there. Again, some movements, but I think that's not interesting or anymore. It just shows the, and again,
so this process of passing the stones to me and me sucking it out was it took us a while, and we realized that we're constantly communicating. We're saying, look, we're going to be here all day if you're going to remove these stones one by one.
Yeah, and then this is why at some point, just I'm going backwards, and that will explain things. Yeah. So here we've decided. I said, look, Kasra is going to take us too long, and maybe you should give it one more go and try to reach with the probe into that calyx. Obviously, he's trying, but you can easily see that the tissue starts tearing, and he didn't push, so he didn't force.
We're anticipating that, but we thought, look, we need to do something else. We need to change that strategy. Let's have a go, see what happens, and which was unsuccessful, obviously, as expected.
Yeah, and he stopped. He didn't do it anymore, and we went back to what we did before. So I continued with, okay, so that's a good image because it shows, you can see me manipulating the scope, the ureteroscope. Kasra is here with a nephroscope, and Alberto, our very skilled registrar, is close to Kasra. So we are working very close together and collaborating, discussing, pointing, looking in the same direction. So the theater setting is important as well. And the teamwork is I love it, at least I love it. And it's really good to have the opportunity to work with.
So just on that point, because it ties in nicely with a comment that Kay's made, you've got, two consultants there, a trainee, you're using kit from below for the endoscopic combined part. You've obviously got percutaneous access, nephroscope, Trilogy, and it's just a question about costs, really. And, you know, there's no increased uplift for an endoscopic combined intrarenal surgery. You know, it takes longer. It is better for the patient. It means that, you know, we don't then have to bring the patient back for another procedure. The patient's more likely to be stone free. And her point really is that, you know, we're not reimbursed properly as hospitals for that. So maybe that's something that BAUS should look at lobbying for endoscopic combined to be properly remunerated, which I think is a, you know, a very good idea. Have you got any thoughts about that?
I think it's really, really important. If you think about it, if you were going to do this, let's say we're going to do it in 2 stages, do a PCNL and do a ureteroscopy. The hospital will get more money, but it'd be 2 trips for the well, you know, just 2 trips for the operation. There'd be 2 trips for pre-assessment, extra night of stay. Even if you do it as a day case, which we tend to do our flexible our ureteroscopies, if you can do it as a day case, it would be an overnight stay for the PCNL and a day case for a ureteroscopy. So the costs are definitely, you get better reimbursement, but definitely something that we should look at.
Yeah. I think that's something that's worthwhile looking at through the BAUS section, really. So that's a very good idea. And then another question about, is there any real risk of damage to the basket with the Trilogy device?
Yeah, so I was trying to answer the question before. Honestly, I was not sure what's going to happen, and we've used it obviously many times. We never broke a basket with Trilogy, and in some of the images and some of the parts of the video, you can see that the Trilogy works in between the wires with the basket there. So I think it might be that it's less risky than compared to when you try to laser the stone in the basket.
So, I mean, I was fully aware of that because I didn't know what it would do. So actually, what I was doing there, generally speaking, I only had to begin with until I got the stone slightly away from the basket. I was using the suction purely. So I'm pressing the foot pedal only halfway down to use the suction. And until I was slightly free off the basket, I wouldn't deploy it fully in order to deploy the energy source.
Yeah, well, I encourage you to do it because it was nothing happened.
Okay, so I mean, time is moving on. I think it would be good maybe to think in the next couple of minutes about, you know, talking about the end game here, nephrostomy, stent, those sorts of things. Maybe just give us a summary of where you got to and how the patient did.
Yeah, so just a few more things that I would like to share with you, because it was interesting for us as well. I think this one, yeah, it's the one when Kasra told you about. So at some point, he was breaking the stone, but not very successful, and there was still some fragments, and again going down to the PUJ, though now I'm much braver with my scope. I stay there, I try to provide some support for him. I know we are more or less towards the end of the procedure, and you'll see that Kasra is going to, yeah, that's it. So basically he sucks the stone when it's small enough to go through the sheath. He sucks the stone with a probe and removes it. So again, a lot of fragments removed. I'm going to increase the speed of the video now. There's one more thing at the end.
So again, I'm sitting sort of away and then sucking, and
yeah, you see, basically they come to the probe and they are destroyed. You don't have to press against the wall. So
yeah, that's a lovely demonstration.
Yeah. So this is that's the moment I said, look, we are doing this for so long now. I'm going to do something which I usually tend not to, or I'm very prudent or cautious to do. Let's stop with basketing. I think we've removed the larger fragments, and that's the view. So that's what's left. So still a lot of stones. I'm asking my colleagues to provide me with the SAPs. You're familiar with the
single action pumping device.
So what I'm trying to flush them out. So with movements, I'm pushing the scope into the calyx and going back down to the infundibulum. With I was asking the registrar who was helping me to be very careful and not to try to avoid very high pressure, and you can see Kasra was sucking in the same time, and the system was not collapsing. I think basically and mostly due to the very long infundibulum. However, it was a very good move because we managed with this in a few minutes. We've managed to clear everything, and you'll see the final images. We are getting there. So this is Kasra's view, and you can see stones getting into the towards the Trilogy probe, and I'm getting out. I'm really happy with the outcome, and there's no bleeding, there's no real damage to there's no fornic structure, and this is a simultaneous view.
Just on the question of fornic rupture, there's just a question that's come through about the pressure, because obviously you're talking about the SAPs, and you know, the SAPs can generate a significant amount of pressure, particularly if you use it during flexible uretroscopy. So you know, how do you judge how much pressure to use, or do you think that in a PCNL, when you've got an open system like you have here, that it's not such a concern?
I think you've answered the question, at least part of it. Yes, I'm really prudent and careful when using SAPs, and most of the time, especially if I'm working with a new assistant or a new colleague, new help, before starting, I want to check what my colleague who's manipulating the syringe or the pump thinks it's, you know, a lot of pressure. Because you might be amazed how easy you can build up pressure and lead to fornic structure, and you have to stop the procedure. So with an open system with PCNL, it looks like it's a bit safer, but I still wouldn't encourage a lot of pressure into the kidney with the flexible cystoscope, with the flexible ureteroscope, as we did here. So very, very prudent and very careful.
But I think in this setting where you've got an open system, plus, you know, I'm providing a negative pressure in terms of sucking quite vigorously, the likelihood of us generating significant pressures in this setting would have been extremely low.
Yeah.
When you're doing a flexible ureteroscopy, it's a completely different story.
I can still guarantee you that, you know, if you're with the ureteroscope in the calyx and you put a lot of pressure, you will, even if you have suction from the pelvis, there is still the risk of fornic rupture. So very, very careful with pressure. And I would like to make a comment at the end, because obviously this is not perfect surgery. It is, as I said, now I'm just checking the rest of the collecting system, which is collapsed now. Yeah, but it looks good. Just some Randall's plaque. We're not going to. Yeah, look here. Yeah, so you can see, and there's not a lot of pressure, and you can see the fornix almost there on the verge of breaking. We've decided that as for exit strategy, we've decided that nephrostomy is not required. We can just put a stent in, and I went back into the calyx where in the upper pole calyx where we removed the stones from, and the guide wire gets in, and that's the end of the video. So
then you've got the guide wire, and then we did a retrograde stent, and Laurian's inspecting the ureter as he's leaving.
Yeah, and you can see on the right the image of the nephroscope going out.
So you've done a fantastic job there. Just talk to us about the exit strategy and how the patient did afterwards, if that's okay. And then just to say to those who've joined us, the delegates, we'll have a couple of minutes for Q&A at the end. So if you've got any more questions, please put them into the Q&A at the end. And then once we finish the Q&A, there'll be information about feedback from this, about how to get your CME as well, and then also about the next BAUS webinar. Just tell us about exit strategy for this case, and maybe exit strategy generally, if you can.
Yeah.
And then also about how this patient did post-op.
Sure. So obviously, we had already discussed in terms of the stent versus nephrostomy, and I and I know Ollie and Laurian, we've moved away from nephrostomy unless it's really essential. I tend to be putting in stents after PCNLs. In this particular case, I don't know if I mentioned at the very beginning, this was a lady who weighed just shy of 100 kilograms, had a history of AF, diabetes, and high blood pressure, and was on warfarin. So obviously we gave the normal sort of standard, catheters and antibiotics post-op. Then the other discussion that we had, okay, what do we do with her warfarin? Do we go on treatment dose of dalteparin? Do we give her prophylactic dose? Do we not give her any dalteparin? But we thought, given her high risk in terms of her weight and her comorbidities and her history of AF, we should give her dalteparin. But also, I didn't want to give her treatment dose of dalteparin soon after the operation, so we decided to go on a prophylactic dose. As a precaution, I also asked the nursing team to put on a pneumatic calf compressors until the next morning, where we could start her rewarfarinization process. And she was sent home on, we have a protocol, anybody who's warfarinized, they go home with dalteparin with treatment dose afterwards until they're fully anticoagulated with their warfarin. And she went home the next morning.
Fantastic. What a good outcome. Good. Any other final comments? We've had a couple of Q&As that I've just been answering. Is there anything else that you would like to summarize from the case?
From my perspective, my learning points from this case.
Yeah.
So regarding strategy, we have been thinking a lot before which calyx to approach, and we went through all possibilities, and planning for PCNL, I would say, is very important. In the end, I still think it was the optimal approach. So the calyx that we did choose was the optimal one. You can use this Trilogy probe. You can use it. It's quite versatile. As Kasra said, it might even work as a grasper. You can even suck things out and use also the same whirlpool effect and suction and irrigation will push fragments out, which is very good. You can fragment the stones without pressing too much on the mucosa. Some of them, you just suck them, they stay in front of the probe, and with the ultrasound lithotripsy, they break. You can easily see them breaking, and you've seen they were not very soft stones. Now, should I have, because I was thinking, should I have tried to flush as my initially, I was thinking, should I flush first and try to pick up whatever's left, or should I get the big fragments and maybe I was too prudent. I didn't want to flush initially because I was afraid of creating too much pressure and compromising that calyx completely, and having to go back on the second. Maybe, so I don't know. Looking backwards, I think I would have done things in a similar way, and I'm happy with the outcome. The laser, the one that it was the first time when I've used it, worked very well. I was very happy with it. You have to be careful when you have a stiff guide wire down to the ureter, because it may impair the scope, the flexible ureteroscope maneuverability. And you have to love what you're doing and to love working in a team. This is a teamwork. It's not, and I like it. That's the amazing part, that you can really get good results for the patient and collaborate with your colleagues.
Perfect. Well, thank you both for sharing with us. I think we should draw things to a close, if that's okay. I want to thank Uli and EMS for supporting the webinar. Thank you, Uli, very much indeed. Thanks again to Laurian and Kasra, and thanks to all the participants for joining. I want to just say that feedback will follow after this, and information on how to get CME will follow as well. Our next webinar is next Thursday night at 7 o'clock, and you can see the BAUS website for registration details for that. And there's also a recording of all of these webinars, which will be available through the BAUS website as well. So you should be able to see the whole of the Innovation in Urology series through that. So please stay online to complete the questionnaire, and your CME certificate will be sent to your registered email address. Thanks again, Uli, EMS. I'll hand back to you.
Yeah, thanks, Ollie, for this nice close-up. And yeah, nothing more to say. That I thank you all the participants. I thank both Kasra and Laurian for this very exciting case. I was happy to be present in the UR, so there was nothing hidden. And just to tell you that the next webinar, EMS webinar, is also on the 10th of December, so in 1 week at 4 p.m. Central European time. And then we will have the pleasure to welcome Dr. Nariman Gadzhiev from St. Petersburg, Russia. He will talk about supine mini PCNL. And there's more webinars to come next year. So watch out for announcements via our channel partner or via Twitter. Thanks again for joining, and have a good night all together. Bye-bye.
Good night. Thanks a lot. Bye.
Bye.